this, we're taking 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 with a pinch of salt.
Dear ERA community, I'm George Kosmadakis and you're today's host of A Pinch of Salt, a series of comprehensive podcasts attempting to familiarize you with activities of our flourishing scientific community. The Renal Registries is one of these kind of activities that you try to avoid sometimes, as you may be overwhelmed by the numbers, you have to admit it. Nevertheless, it is over there that you are always looking for a catchy phrase to start your articles with, and also whenever you have to answer questions about your job in a cocktail party. Admit that as well. I have always been peculiarly attracted by numbers as they don't lie, very often. And today we have the honor and pleasure to discuss with Professor Alberto Ortiz, Chief of Nephrology and Hypertension at Fundación Jiménez Díaz in Madrid, Spain. Alberto does translational and clinical research in molecular biology, cell biology, and bioinformatics applied to kidney disease, hypertension, and vascular disease. His current projects aim at identifying novel mediators of kidney and vascular injury in order to develop novel risk stratification and therapeutic strategies. Alberto is also chair of the ERA Registry Committee and is joining us today to talk about ongoing studies conducted by the registry. These are studies on a new way of thinking about primary disease codes and genetic testing. Today, we have the pleasure to be face-to-face with Alberto in the press room of the Congress Center in Stockholm to discuss about it. Alberto, thank you for sharing with us a few minutes of your extremely busy schedule.
Thank you, George, for the kind invitation to share knowledge about the registry.
So I will move on straight to the first question, and I will ask you about the registry. Where is the registry based, and which is the current staff?
Okay, the registry is based in Amsterdam, in the Netherlands, and it is currently staffed by 11 brilliant epidemiologists, roughly equivalent to 7 full-time equivalents of job workload, and it's directed by Vianda Stel. Additionally, these epidemiologists are supervised by a registry committee which consists of 12 members representing the ERA president, the chairman of the registry, 4 elected by national renal registries, 4 nominated by the ERA Council, and 2 by the European Society of Pediatric Nephrology.
So we have also pediatricians as well, and this is very interesting.
Yes, we are interested in the full life spectrum of chronic kidney disease.
Well, things have really evolved during the last 20 years. This is wonderful. And I will ask you concerning the activities. Which are the 3 main activities of the renal registry?
Well, the registry collects data on kidney replacement therapy and, as we'll see later, also earlier stages of CKD, analyzes this data and distributes the results and information through publications, reports, and presentations. It also has a coding activity for cause of death and primary renal disease, and also has educational activities such as an annual course on basic epidemiology related to the kidney.
This is a very interesting course, and is it in Amsterdam, this course?
No, it is every year it's held in a different place, and we try to move from north to southern Europe, from the east to west.
Perfect distribution. Can you please elaborate on the latest groundbreaking research project you are working on with the registry?
Well, there are so many, are so interesting.
Yes,
So first we are trying to expand to cover the full chronic kidney disease spectrum from CKD G4, G5 to our current interest, what we are actually working now, which is in kidney replacement therapy. So we want to expand to earlier stages of CKD, and we also want to fully intertwine this data with transplant data. So to cover the full spectrum from CKD, G4, G5, kidney replacement therapy, dialysis, transplantation, and potentially back from transplantation to dialysis. We are also very much interested in the cause of chronic kidney disease. We believe that times are changing, genetics is here, but we nephrologists, we are not doing genetic testing. So we are trying to visualize the impact of genetic kidney diseases on the overall population on kidney replacement therapy. Traditionally, only polycystic kidney disease is reported in the data summary. So we aim to report congenital abnormalities of the kidney and urinary tract, CACUT, and inherited kidney diseases as a category, because some CACUT are inherited. So these should be the categories that would require genetic testing to be diagnosed. If we change from just showing PKD, polycystic kidney disease, to showing all CACUT inherited kidney diseases, the incidence would double from around 5 to 9%, and above all, the prevalence of these conditions with the overall kidney replacement therapy population would increase from 9 to 18. In fact, CACUT and inherited kidney disease would be the most common cause of prevalent kidney replacement therapy in younger patients down with the age lower than 45 years, and also in women. And this is an underestimation because we are not doing enough genetic testing. So this is just the tip of the iceberg of the impact of genetic kidney diseases. What else are we doing? We are trying to assess the heterogeneity of kidney care throughout Europe, so as different countries can use it as benchmarking to improve the quality of care. In a recent example from Finland, the registry data told the health authorities there that they were not doing enough preemptive transplantation, which is the best treatment for kidney failure. Better than starting dialysis is to start with a kidney graft. So since then, since becoming aware, and the Finnish nephrologist talking to the health authorities, there has been a huge increase in preemptive transplantation in Finland. We also are aiming to redefine the public perception of chronic kidney disease. So to some health authorities, chronic kidney disease is a no problem, because if kidneys fail, you can replace kidney function with dialysis or kidney transplantation, and they are happy with that. But the registry shows that if you are a 20-year-old woman on dialysis, your life expectancy is 45 years less than in the general population. And if you are a man, it's 35 years less. So yes, dialysis transplantation, they prevent immediate death, but they do not fully correct the main impact of chronic kidney disease, which is accelerated aging and premature death. So we should put our effort on preventing chronic kidney disease. It's not enough that we offer kidney replacement therapy. We should strive to prevent people from ever needing kidney replacement therapy. Finally, another very interesting project, we are defining the normal range of glomerular filtration rate of kidney function in the European population. This would allow younger people that do not meet the criteria to be diagnosed of chronic kidney disease based on glomerular filtration rate, because it's above 60 ml per min, but they may still have a lower than expected glomerular filtration rate, and they may, in my vision, they should be undergoing testing whether there is early chronic kidney disease there.
So the specter of activity is increasing from one year to the other, and you have talked about the specter of all stages of chronic kidney disease, the genetic kidney disease, the heterogeneity of kidney care all over Europe, the public perspectives. This is a huge array of activities for the registry, and it is evolving every year. You have stressed about the impact of chronic kidney disease as a non-communicable disease that was 13th place in the world, and now
Yeah, it's projected to become the fifth
Fifth.
global cause of death by 2040. And 2040 is just 16 years away.
yes, of course.
But we have made also projections in Spain. You know, Spain is a very special country because it's projected to be the country in the world with longest life expectancy by 2040. And we project that chronic kidney disease will be the second cause of death in Spain before the end of the century. And this seems very far away. But people living by the end of the century, they are already being born.
Yes, and if you have to do something, you have to do it now if you want to have the results in 2040. Of course. Well, that's very interesting. And what about the educational activities of the Renal Registry?
I think it can be divided in two. So the Renal Registry writes papers on education about kidney epidemiology mainly from the European Renal Association journals, Nephrodialysis, Transplantation and Clinical Kidney Journal. Additionally, it holds this annual course on basic epidemiology, which is a hands-on course. So this is why only around 40 people can do it every year. So it's a 2 days course, full-time, some theoretical background, and then hands-on on the computer. And it's very highly valued by participants.
So you are inviting people to participate if they can.
Yes, please.
That's perfect. That's perfect. Well, could you please comment on in the work concerning the assistance in coding and the definition? I know that's something that you are actively implied.
Yes, so the ERA registry has codes for primary renal diseases and codes for causes of death that are updated regularly. And now we are undergoing an update. Regarding primary renal diseases, in the ERA registry jargon, this is PRDs, primary renal diseases, well, there has been a huge recent change. So some conditions have been born, such as APOL1 nephropathy,
Yes.
and others have changed names regarding, for example, ANCA vasculitis, that previously it had names from individuals.
Yes.
And we expect even more changes as genetic testing becomes more widespread. So this is why we are updating the causes of primary renal disease so as to keep them up with the times.
What wonderful times. Things are changing very, very fast. I have seen a couple of papers and I was really amazed with the results of the EQUAL study.
Yep.
Could you please comment?
Well, I think this is a key study. So the chronic kidney disease is increasing, but mainly in the elderly, and we live longer and longer. So maybe our kidneys will not live as long as we do. So there is this key question: what's the best way to treat kidney failure in the elderly? So the EQUAL study is a study on treatment of advanced chronic kidney disease in the elderly people above the age of 65, recruited from 6 European countries that at baseline they have chronic kidney disease category G4 or G5, so eGFR below 30 mL per min. It has already recruited over 1,700 patients with a follow-up of 8 years, and it's addressing several questions, but I think the key one is when is the optimal timing of initiating kidney replacement therapy. And there have been some interesting results because these people, they are the elderly, and you know there is a movement now that maybe the elderly do not benefit so much from kidney replacement therapy. They may be candidates for conservative treatment.
Another frequency of dialysis?
Or another frequency of dialysis, yeah. But I think that mainly the discussion is around conservative treatment.
Yeah.
So it has been said that by conservative treatment, you preserve the quality of life because patients do not need to go to dialysis, etc. However, EQUAL showed that quality of life decreases rapidly in the time just before you need to start kidney replacement therapy. And thereafter, it stabilizes. So there is not a negative impact of kidney replacement therapy on quality of life in the elderly. Rather, in my view, it prevents further deterioration of quality of life. So the study is ongoing, and I think it will provide key answers to key questions are we as a society get older and older.
And I remember some older studies that were stressing the evolution of the quality of life parameters in different age groups. And I remember that the patients of a certain age had a lesser reduction of their quality of life after the initiation of dialysis compared to younger age groups.
Yeah, that's likely because younger age groups, dialysis interferes with work, with social life, and some elderly patients, they have very little social life.
Or the dialysis is their social life sometimes.
Yeah, so 3 times per week they go there, they meet friends, they meet their staff. I remember vividly special individuals for whom dialysis changed completely their social life, and they were the most talkative in the waiting room for dialysis.
Sometimes the birthday cake they receive in the dialysis unit is the only birthday cake they receive in general for the year. Yeah. So, Alberto, if somebody is interested in the activities of the registry or want to collaborate, I'm jumping this question because I suppose that some people who might listen to this podcast might be interested to know more and to work with you. Is it possible?
Yes, of course, and we are awaiting potential research questions. So they can either contact me, my email is publicly available, or Vianda Estel, who is the leader, the director of registry now. They can also follow all the ERA newsletters in which there is information there on how to apply for fellowships in the registry to complete a research project. So through this official pathway, they can present themselves as candidates for the fellowship and present the research idea.
So, dear colleagues, if you're interested, don't hesitate. And that was a wonderful discussion. I will pass on to the typical personal questions, Alberto. And the typical question is whether, if you were in a desert island, which book, luxury item, and 2 songs would you take with you?
Okay, maybe my response will be a little bit atypical because when I imagine a desert island, I would love to watch nature there. Yeah. So I can imagine the mountains, the sea, the underwater marvels. So I would bring nothing at all. I would be there enjoying nature.
Well, if it is underwater, probably you should take a tuba mask to.
Yeah, but yeah, that would be the item. You wouldn't even need a bath trunk because you are alone there.
Yeah, you would sing alone. Perfect. Well, you are from Madrid. Would you like to tell us something about your town?
Yeah, I want to tell something that very few people know, and I think it's very interesting for the nephrologists. It's the European capital, which is situated at the highest altitude over sea level.
Oh.
And that's interesting because year after year after year, Eurostat data on life expectancy by region places Madrid women on the top of life expectancy.
Oh.
And Madrid men, they are struggling with some regions in Italy and Sweden.
Yes.
But so if you want to live a long life, move to Madrid.
Does it have to do with the altitude? Or is it your way of life, the Mediterranean food?
Well, but you also have Mediterranean food in Barcelona,
yes,
Valencia.
Yes, of course.
So we don't know what's the reason. my hypothesis, it has to do with the altitude.
Right.
There are data from Austria, which is relatively uniform in socioeconomic terms, that the highest over sea level you live, the lower the overall mortality, the lower the cardiovascular mortality, the lower the cancer mortality. Why this might be? Well, if you live there, your hypoxia-inducible factor, HIF, is activated as compared to sea level. We don't know whether that's the reason, but, well, these are facts. Highest capital in Europe, longest life expectancy in Europe, Madrid.
So it's wonderful. Well, I love Madrid. I have been a few times. I really love this town. I can go all day. So, dear ERA community, I could go on forever asking questions, Professor Ortiz, but I have to go to try a pickled herring, a famous dish of Sweden, washed down with a couple of liters of water, I suppose, because I think it will be a little bit salty. I hope you enjoyed this wonderful experience shared with a leader on the subject. Stay tuned for more podcasts on very interesting issues available on many platforms like YouTube, Spotify, and of course the ERA site. Check it out.